Hello, all of you. We have the pleasure of having today a kind of symposium amongst three researchers from the different corners of the world. So we have Dr. Ronald Orinola Zapata from the University of Minnesota, Dr. Giamperio Rossi Feder from the University of Adelaide, and myself from the University of Hong Kong. If at all, one of the good things that's happened out of this COVID-19 situation is that it's gotten all of us together in terms of sitting at home and having the pleasure of listening to numerous speakers around the world. Okay, now endodontics has undergone leaps and bounds of changes over the past several years or decades. And we've had numerous developments in terms of new instruments, new alloys, different surface treatments, different kinds of materials for root fillings, as well as a lot of these cool gadgets which help you in activating irrigants and in filling root canals. Regardless of that, our outcomes have not dramatically changed. If you look at this table, it shows us very clearly that as long as the pulp remains vital, our success rates are very, very high. However, when you have a periradicular lesion, our success rates drop down dramatically. And this is because we have an infection that is present. And every time we have an infection, the healing of periapical tissues is delayed. And we study these outcomes. Our primary outcome here is the healing of apical periodontitis lesions. And we study that clinically by directly using radiographic approaches that look at healing, or we study the surrogate outcome measures. And these surrogate outcomes may or may not be linked directly to this primary outcome measure. So what are the surrogate outcomes? It can be microbial reduction. It can be how much of pulp tissue that we remove, the removal of smear layer or hard tissue debris, as well as extrusion of microorganisms and debris. However, it has been well documented that the only validated surrogate outcome measure is microbial reduction, which implies that when you reduce microorganisms from the root canal system, you facilitate healing of apical periodontitis lesion. The other outcome measures can be easily linked to healing or to microbial reduction, but there's no direct evidence to show that. Regardless of that, all of these outcome measures are important just from a logical standpoint. And what do we know in terms of this microbial reduction? We know that the pathology will persist if your disinfection protocol cannot reduce the microorganisms. So that is what we call the subcritical threshold. So you want the disinfection protocols to reduce the microorganisms to a threshold which is below this limit so that healing will take place. However, the problem is that from the context of root canal treatment, we do not exactly know what this threshold is. Of course, it will vary with the patient's immunity, the anatomy, and a whole lot of factors, which is why it is important for us to strive towards achieving optimal disinfection, simply because we don't know at what threshold inside the root canal healing will start taking place. And we achieve this process of debridement by a combination of instrumentation and disinfection. And from the instrumentation perspective, it is well known that although the instruments alone, you can be using rotary instruments, reciprocating instruments, any kind of instrument, we know that when you instrument root canals, you can remove a lot of the septic content from the root canal space. This is from the main root canal space. But remember, the root canal system is not just the primary root canal alone. You have a lot of accessory anatomies which the instrument is not going to touch. So no file has ever been disinfected, has been designed to disinfect the entire root canal system. All that the instrument can do is shape the root canal walls so that it can facilitate cleaning and then obturation. So we can understand that instrumentation, although it can remove a great part of the septic content, it cannot eliminate it completely, and all this is limited only to the main root canal space. And we also know from a lot of these studies which came about at least a decade ago that none of our instruments can touch more than 50% of the root canal walls. Now, with some of the modern instruments such as the XP Shaper, etc., it may be possible to touch more number of walls, But with a vast majority of the rotary or reciprocating instruments, we don't touch all the parts of the root canal wall. Like, for example, what this micro CT shows is parts of the root canal wall where your instrument touches, that is the green, and the red is where the instruments don't touch. Now, in 2020, this is common knowledge. We understand that our instruments do not contact all the parts of the root canal wall. So, what happens to these walls that are not touched? This was reported about 2 years ago, where authors from Brazil looked into vital and necrotic molars and premolars that were instrumented and irrigated with sodium hypochlorite. And then they looked at the number of walls that were not touched by the instruments, and they also looked into the amount of tissue remnants. And they noticed that in molars and in premolars, at least 20 to 30% of the walls were not touched by the instruments. And these untouched walls housed a lot of vital tissue. And in the case of necrotic teeth, they contain debris, microorganisms, etc. So in the areas where your instruments do not touch the root canal wall, you have a lot of debris that is still being retained. This could be microbial biofilms. This can be vital or necrotic tissue as well. So our key challenges in endodontics can be microbiological, they may be anatomical, or they may be structural challenges. What are the microbiological challenges? What you see here are the two most common modes of microbial growth. This is called a planktonic suspension, whereas this is called a biofilm mode of growth. What is different between these two? Remember, these biofilms form the entire root canal as well as within the complex anatomies such as the dentinal tubules. Now, the key difference between planktonic and the biofilm structure is the basic organization. A planktonic suspension is very simply like a pile of stones. You can very easily disperse them, whereas a biofilm is more like a brick and mortar wall, which means that just by depositing solution of any liquid, you can't break down this entire structure. And every time when we have biofilms in areas of the body which are not normally used to having microbial presence, you have inflammation. What is very critical about these biofilms is the basic structural framework. What you see here is a simple net, say a fish net, for example. What the biofilm has is this net-like protective structure, which is called the biofilm matrix or the extracellular polymeric substance, the EPS. So the EPS can contain numerous chemical compositions. It can be carbohydrates, proteins, lipids, genetic material, a lot of these things. What the EPS does is primarily protect the biofilm bacteria or other organisms from the action of antimicrobials. For example, if you take planktonic suspension and treat it with an antiseptic, the antiseptic will very easily diffuse into the liquid and go and kill these microorganisms. In contrast, in a biofilm, the biofilm matrix protects these microbial cells from the action of antimicrobials. It reduces the diffusion of these components into the biofilm. More importantly, the matrix serves as a framework where reinfection can happen. Imagine a fishnet. You have fishnet and you have dust which sits on the fishnet. If you wash this fishnet and you remove all this dust, and if the fishnet structure still remains, new dust can sit on this fishnet and result in re-dirt formation. Same thing happens inside root canals as well. If your biofilm matrix remains intact, then new microorganisms can come and sit on this matrix, resulting in reinfection. So the biofilm matrix has three important aspects. It makes your biofilm more tolerant to the antimicrobials that we use. It enhances the recolonization of infections. Thirdly, it will protect the biofilm and the biofilm cells from the action of antimicrobial agents. So it is very important for our strategies to not just kill microorganisms, but you also want these root canal disinfection strategies to be able to break down these biofilms. And very recently, there was evidence published by Professor Ronald in Toronto, and where he showed that the matrix is extremely important in causing long term inflammation. Till this research was published, it was oftentimes thought that the number of bacteria or the number of microorganisms in the biofilm is mainly responsible for inflammation. But now we know that even if the microorganisms are removed, the biofilm matrix alone can result in a sustained inflammatory response, which means that our disinfection strategies have to critically disrupt and dissolve these biofilm matrix components. And one of the persons who has done some extensive work on the effect of disinfectants on biofilms and biofilm structures is our other speaker, Dr. Ordinola Zapata. Now, Ronald will probably discuss on what the effect of different disinfectants on the biofilm are.
Okay, thank you, Prasanna. Can you hear me?
Yes, can
Okay,
you
I
hear me?
think
Yeah, go on, go on. Yeah.
yeah, I think it's doing well. Okay, thank you for the invitation. As you know, I'm completed a master and a PhD in endodontics at the University of São Paulo in Brazil, and got a specialist certificate at the Albert Einstein Medical Center. And currently, I am an assistant professor at the University of Minnesota. So, from the microbiological point of view, our goal is the elimination of the infection and the sealing of the root canal space. And it is very important to avoid destroying the tooth in the process. So what you're seeing now, these are called confocal laser scanning or microscopies. And then you will see in the left side, this orange substance. It is basically the biofilm that is attached to the root canal walls. So this biofilm, as Dr. Nilakantan just mentioned, they can produce the EPS. And this EPS, it can react with our antimicrobials, especially some concentrations of sodium hypochlorite can be depleted of the concentration because of this biofilm. This biofilm is basically a number of cells, several layers of cells that are compacted and are irreversible attached to the root canal walls. So basically, our goal as endodontists is to use hand instruments, or rotary instruments, or reciprocation instruments to try to scrap this biofilm that is attached to the root canal walls. Because the anatomy sometimes is very irregular, we need to use some proteolytic agents such as sodium hypochlorite so we can dissolve chemically this biofilm. So basically, it's a very simple concept. We just need to clean the wound of the that is inside the tooth, basically. And once we are assume that the tooth is already clean from the inside, we need to seal the root canal space. As you know, the mouth is a very contaminated area. So we just want to avoid leakage inside the root canal. And in order to obtain this goal, we are going to use gutta percha and sealer. So the gutta percha and sealer basically is just going to prevent the recontamination of the root canal space after the cleaning and shaping. And one of the first authors that completed research on this topic was Grossman. So he did this interesting paper. This paper has probably more than 70 years. And he evaluated different substances to check the ability to dissolve human pulp. As you can see, he tried a very few amount of liquids like hydrochloric acid, enzymol, sodium hydroxide, or papain. We have also sulfuric acid. And among all of these irrigant solutions, he found that sodium hypochlorite was the most effective liquid to dissolve pulp tissue. So after this work, the use of sodium hypochlorite was very popular. And I personally completed some experiments in the past. This is one of my first papers on dentin infection. It probably has around 12 years since this paper was published. And we start to do some research on the effect of root canal irrigants on biofilm infected dentin. These are basically in vitro experiments. It doesn't mean that this is going to happen in your patient's mouth, but it's a very nice way to control all the variables and to see how the bacteria interacts with different irrigant solutions. So I'm just going to explain all these experiments very briefly. So the first question was how to obtain a biofilm. Of course, it can be a little bit complicated to create a biofilm in the lab. So I took this model from a Barthel article where volunteers used a bovine sterile dentin that they were attached in these orthodontic devices or Holey devices. So after 2 or 3 days, these dentin blocks were taken out from the removable device and were scanned in a microscope. And what we found is that if we we put a small piece of dentin in a removable orthodontic device, after 3 days, we are going to have a very thin layer of biofilm. This layer had around 20 to 30 micrometers of thickness. So we have dental plaque. You can see in green is all dental plaque covering the dentinal surface. As you know, a 10K file has a diameter at the tip of 100 micrometers. So this biofilm had less than half of the tip of a 10K file. So our rationale for this experiment was if the irrigant cannot kill 20 micrometers of biofilm or dental plaque under a direct contact test, probably the irrigant solution will have little effect inside the root canal, where the contact of the irrigant with the canal walls is more complex, because inside the root canal space we have bacteria, we have other type of fluids, exudates, sometimes we have pus or bleeding that can inactivate our irrigants. But this was a very simple experiment. And the advantage is that you can see that there are like 2 types of colors, or one is red, the other one is green. Just basically tell us in a simple way if the bacteria, it is live or dead. But the stain basically measured if the irrigant solution affected the cell wall. So one of the results that we got was that even if you use, for example, 2% chlorhexidine in this very thin layer of biofilm, even for 30 minutes or half an hour, we didn't found any dissolution effect. The same happened for distilled water. And on the other hand, when we use 2.5% sodium hypochlorite, that is a diluted concentration, even for a small short period of time, such as 5 minutes, you can see in this picture how the liquid, they attach the biofilm from the dentinal surface. So it has a very profound effect on the biofilm architecture. So one of the conclusions that we found in this experiment is that all the sodium hypochlorite concentrations show a significant effect on the biofilm architecture. And in the same experiment, we saw the influence of the time. And sodium hypochlorite, as you know, is a very reactive chemical compound. And it's very interesting because even if you use low concentrations of sodium hypochlorite, you can compensate the lack of tissue dissolution increasing the time. You can see we are observing like a sagittal section of the biofilm. You can observe that the more time the liquid is in contact, of course, you need to refresh every 5 minutes the sodium hypochlorite. So the more time this liquid is in contact with this infected dentin, the more increased the dissolution effect over the biofilm. So it is just basically a matter of time. So if you have enough time irrigating the root canal, probably you will have a significant dissolution effect of the biofilm. So another conclusion that we had was that the all sodium hypochlorite solutions were able to dissolve a significant amount of biofilm if you increase the contact time and if you increase also the concentration. And in another paper, this is from the IJ, I personally try to evaluate the different compounds that are used for the irrigants. And one of these is EDTA and chlorhexidine. So basically most of our irrigant solution has distilled water or EDTA chlorhexidine or sodium hypochlorite. So the main conclusion was that even 1% sodium hypochlorite was more effective than 2% chlorhexidine or EDTA to decontaminate the dentinal surface. And in another study, we also found that it wasn't, or the sodium hypochlorite was superior to not only chlorhexidine but also to antibiotics. You see, we have still water in MTAD. MTAD was an irrigant solution. I think it's not in the market anymore, but had doxycycline. I'm sorry, that is an antibiotic. It wasn't effective. The same for Alchemix or 7% malic acid or smear clear, that is EDTA plus detergents, and even your IKA, that is iodine potassium iodide. It wasn't effective, or it wasn't so good compared to all these oxidating agents such as the low and the full strength sodium hypochlorite concentration. And then you can see what was the result of the direct contact test of the irrigant solution with all these different commercial compounds. It was basically a very limited antimicrobial activity from this point of view. In these images, you can observe on the left side, there is a microscopical field of sodium hypochlorite treated dentin at 2.5% at the full strength. And if you observe in the magnification in the right side, you will note that there are like some green dots. These green dots are bacteria inside the dentinal tubule. So what happened is sometimes the contact time is not enough to dissolve completely the biofilms. We may have some bacteria inside the dentinal tubules, and this bacteria is probably not resistant. The difference is that maybe the sodium hypochlorite concentration at that level was not enough to kill this bacteria. But of course, we can see there's a difference in the amount of biofilm volume when you use sodium hypochlorite or not. And another variable that also I would like to talk about is the anatomy. Of course, you will find that a lot of, I will just say, dental companies are trying to improve the mechanical behavior to try to clean lateral anatomy. So basically, you can see this, we have a mesial root of a mandibular molar. We can observe in red, this is the preoperative for the root canal before the instrumentation, and then you can see in green after the instrumentation. And then when we superimposed the pre and the post-op, we can see that the instrumentation perfectly clean all the denting around the root canal space. So the problem is that we don't know if this is happening in our patients because they may have several different types of anatomies. So what happens in reality is this. So the instrument will perform well if the anatomy is simple, such as in the left side, although we have some areas in red that were not instrumented, you can see that the situation in the right side is much worse because this anatomy is more irregular. So we just need to rely on the sodium hypochlorite ability to dissolve the tissue in these areas. And this was proved by Dr. José Siqueira from Brazil. He has been performing several experiments trying to see the cleaning ability of different night-eye instruments. Basically, we always found, or he always found, that it is almost impossible to clean mechanically completely the root canal space. As you can see, the tooth on the left is more complex than the tooth in the right side. So obviously, your irrigation process is going to be compromised in the left side. Maybe you will need to use more activation, more time, or probably a calcium hydroxide medication to try to clean as much as possible this root canal system compared to the tooth in the right side. Unfortunately, it's very hard to anticipate the complexity of the anatomy. So we just try to guide us, observing the patient's symptoms, probably the size of the lesion, the age of the patients, try to anticipate how much pulp do we have in the root canal space, and probably what type of infections do we have, if it's a recent infection or it's a very long-standing infection that has been in the tooth for several years. So basically, the anatomy is the problem in necrotic cases. This is how it looks on a transversal cross section in a mandibular molar at 1 millimeter from the foramen. So we don't have round canals. They are very irregular. And most of the time, the success or failure will depend in the ability of the clinician to clean this complex anatomy. And sometimes, if we are lucky, like in vital cases, probably on the ability of bacteria, so we have a lot of success in endo, maybe because the immune system is not avoiding or is avoiding the bacterial colonization at this level. However, we should assume that the full canal is always completely contaminated and do our job as best as we can. Now we are going to continue with Giamperio is going to address this topic about how can we improve the dynamics of the irrigation. Okay, Giamperio, you can go.
Thank you. Thank you, Ronald. I need to be able to share screen.
Giamperio, I think you need to open first the keynote, maximize, and then just share
okay.
This button. Yeah.
Sorry, guys. Can you see me?
Not yet.
Okay, but can you hear me? Yes.
Correct. Yep.
Okay, be patient, guys. I'm really sorry for that. Hello, everybody. Can you see me now?
Yes, perfect. Yes.
Okay. Thank you very much. Sorry, guys. Sorry. Thank you, audience. Thank you, Ronald, for inviting me, and also thank you, Prasanna. So the topic I would like to continue now is root canal irrigant activation, which hopefully complements all the interesting concepts shared by my colleagues. Now, I do a quick introduction. I'm Italian, but I became an endodontist in London at UCL under the direction of Professor Gulabiwala. I also was a clinical tutor there for some years. Then I was one of the founders of the course in endodontics awarded dentistry in the UK. At the same time, I did my PhD in Brazil, in PUC, which makes me also have some common story with Dr. Ordinola Zapata. And currently, I'm the head of endodontics in Adelaide. Now, why do we need to do this irrigation? We always need to ask why do we do things, and there are some goals, there are some objectives. So we need to remove debris and wet the canal wall, and this is actually one of the most important factors that we tend to forget. We need to kill microorganisms in infected root canal spaces. We need to dissolve organic debris, mostly in vital cases. We need to open the dentinal tubule and remove the smooth layer. But we also need to remember what Dr. Ordinola Zapata was saying. We need to go laterally. We tend to think a little bit too much about working length. There is also working width. So by preparing our canals, we clean the main canal, but there is the lateral spaces that need to be cleaned. And that's why we need our irrigants and our agitation. Now, what is agitation? What is activation? It's often confusing. Some people consider them to be different concepts, but I would like to know what are we activating as well, and why are we activating? It's always good, in my opinion, going to the glossary of endodontic term. Definitions have been discussed for a while by experts, and there is some degree of agreement. If you see, it's hard even to find a consistent definition of what is irrigation, and we could go back and read them. Now, interestingly, the word active irrigation includes the word agitation. So there is some of overlap, a little bit of disagreement and confusion, but it's using mechanical or manual agitation to enhance physical and chemical debridement of canal contents. This is in comparison with passive irrigation, which is just placing your chemicals inside the canal with your needles. Now, we have to say that normally this active irrigation follows the passive. So it's something that you use in addition, not as an alternative. Now, what are we activating? What are people using? Because often we get asked, what are people using as irrigants? Well, there are several surveys in different countries for different type of clinicians. This is a recent study from the US, where we see that generalists use very commonly sodium hypochlorite as your primary irrigant, and they actually aim to remove the smooth layer. With that, it means that they add a chelating agent. So the use of these solutions is actually the most common sequence in endodontics for general dentists in the US. Now, if we go to Germany, we could see that the younger colleagues almost always use sodium hypochlorite, although there are some differences that are based on the schools. So clearly what is used, well, the main irrigant is sodium hypochlorite. And this is actually confirmed by specialists in the US. Now, we always tend to think that specialists are those that do the best job, so let's see what they do. Now, again, the use of sodium hypochlorite is extremely frequent, as well as EDTA. So these are the chemicals that we normally use. But, okay, what do we do with it? Well, if we go to the specialists in the US, ultrasonic activation and sonic activation are very, very frequent. So not only what we use, is how we use it. These are the two things we always need to think about. This is similarly, this is a survey based in Spain. Now we have general dentists and endodontists, and you see the use of sodium hypochlorite is extremely common, especially on endodontists. Again, the irrigation force mill layer is extremely common for endodontists and less common for general dentists. So if you see there is a trend, which chemicals we use. So specialists tend to use EDTA after or in association with sodium hypochlorite, where general dentists may use it a little bit less. Agitation. Well, agitation, when we go to the right pie chart, we see how common is agitation. Now, endodontists use quite a bit of agitation, while general dentists less. So to some degree, endodontists consider that it's best practice to not only use some specific chemicals, but also to agitate it, to make it work. Now, there is a lot of discussion, do you use sonic, ultrasonic? This is something where there is a lot of inconsistency in literature. There will never really be a full agreement, and there are differences in frequency, in the sort of stress that will have more action over the biofilm and over the debris in the root canal. And apparently, or it is suggested, the ultrasonics will cause this sort of dynamic. So you will have a larger circulation in some smaller areas of circulation, which is called acoustic microstreaming. Now, I always ask myself, will this really happen if I'm inside the root canal? Let's say this root, if you see we have two canals that merge apically, will the ultrasonic tip be free enough to allow it for having this sort of movement? So perhaps we have some action, but it's a little bit limited by the fact that we are working inside a tooth. There are some physical restraints. So what happens? Happens that maybe these sonic and ultrasonic have not such a big difference, but this is all in vitro. We always need to think that we are agitating, but what are we agitating? I remember I worked as a dentist, a general dentist for many years, and I was rinsing root canals with something, but I really didn't know what I was using. It's a water solution, has got a very variable concentration. Some countries 0.5 is favored, some countries higher are favored, and they have other chemical characteristics like pH. They have some salts, some have surfactants, and some other things we don't know. Now, interestingly, I moved to Australia 6 years ago, and I realized that every single root canal irrigant does have some surfactants, but they also have things that they don't tell you. It's secret. They will never share with you. So it's these variables in the formulation that might actually change the effect of your irrigation regime. Now, sodium hypochlorite is by far the most popular. We know it from all this research, from all these surveys, and actually has got something very special, which is the ability to dissolve organic debris. But not only the remnants of pulp, the large part of pulp, but it's also able to digest the biofilm as my colleagues, or to make it softer, to make it easier. So this is really the star ability of sodium hypochlorite. We often use it in association with EDTA. As we say, it's a chelating, has got a neutral pH, various concentration. Again, it might have surfactants. So what happens? This will change how things work during agitation. We sometimes think that this root canal is like an empty space waiting for our liquids to go down. No, that's not the case. This is an experiment from the European University of Madrid. We did something very simple, very obvious now. They were on the top, we had some apices that were sealed and some that were open. Now, this is a little bit more our clinical reality on image D. If you see, our chemical doesn't really go to the tip, where is where we really need to get. So many of the experiments have been done in a status like C. An open space, chemicals go down. We have air. We have another pre-existing solution, something else inside the canal. We need to replace it. We need to move away that air. So we did different activation agitation techniques. And if you see, we use sonic and ultrasonic activation and our penetration enhanced. So using passive ultrasonic agitation or sonic makes these chemicals go a little bit deeper. Now, you normally see this sodium hypochlorite inside the root canal is always doing bubbles. There is already air there, we make more bubbles. So what happens? We need to move, displace, break down, do something with these bubbles. Those bubbles are protecting, are preventing our chemicals from touching the root canal walls. And they are also preventing the chemicals from going to the length that we desire. Now, these are images. On the left is a diagram from Professor Golavivala. You see this, let's say, gutta percha color. That's the area where we are able to prepare and possibly fill. But the space in the middle, that has been shown very clearly by Dr. Ronald Zapata in his images, is an area where we cannot really chemically, we cannot physically treat, but are our chemicals, our dressings that will make the difference. And if our irrigants don't get to the apex, we have this biofilm at the tip of the root, which is what causes the disease. So if we irrigate everything but not the tip, we leave really what is clinically relevant, which is the infection at the apex. We know from millions of studies that all this sort of agitation will increase the penetration laterally and apically. This is, again, more studies from my friends in Madrid. You see how the different chemicals made visible with red dye or radiopacified enter a lot deeper in the spaces if you agitate them. So it's a really important concept. We need to get deeper, we need to get laterally. Another thing, how do we want these chemicals? We want just laminar. Laminar means the liquid goes everywhere. But on the right side, we see something a lot more active. The liquid is there, but it's actually causing friction, causing damage, removing debris, removing biofilm. So we don't want just the chemical to be there. We want also the chemicals to be active and doing their job. Now, this was a very preliminary study was done at the ISPAN when I was there. And there was the addition of different chemicals to sodium hypochlorite. And when you agitate it, actually, there was a big difference if you have added surfactant or thickeners to the solution. So the cleaning of the walls was a lot better. That's why it's important to know not only about sodium hypochlorite, which sodium hypochlorite you have. And from there, with the Madrid group, we done series of studies where we tested, okay, what's going on? What is the real effect? The people in Madrid are very careful. They work really well. They split these teeth. They create a little slot. They place a little bit of porcine tissue, and then you have a normal irrigation in this little groove. So what did we find? Now here we compare sodium hypochlorite with surfactant and without surfactant. So this one, plain, means it has no surfactant. This one has surfactant. And if you see, there is always an effect. So if you have a surfactant, there is a little bit better dissolution. And this can be enhanced by activation. If you do 15 seconds of activation, it improves. And we noticed that there's a twofold factor, two things that work together. So it's not only agitation or surfactant, it's what is added to the chemical, what makes different. Here is a similar study where we compare different agitation techniques with the same hypochlorite, and we find that really what the important thing with this chemical is just to agitate. That's the important message. Now, I like to talk about tissue dissolution because it's a much easier, a much more predictable way to assess root canal irrigant penetration as Dr. Dinola Zapata said, creating a good biofilm is quite difficult and you have a lot of variability. Now, in the past, we have done studies dealing with temperature. Now, we noticed that putting sodium hypochlorite in heat increases the dissolution, and these seem to be a good idea. But then what have we noticed? We have other papers that tell us clearly that if you put a little bit of sodium hypochlorite inside someone else's root canal space, this chemical temperature will go down. So heating or cooling down sodium hypochlorite or any other irrigant before placing it inside the root canal space is not really a good strategy, because the temperature will just become the body temperature after a few seconds. We are now testing other chemicals that you mix them and you put them inside the root canal, and then they start having tissue dissolution. They are able to increase our tissue dissolution ability. But this is heat that is created inside the canal. So as I tell you, it's not only the physics, it's also the chemics. It's mixing things together. Now, this is a simple study where we infected several root canals and we tested a very weak antimicrobial agent, which is CTTA, and a very good one, which is peracetic acid. And what we noticed, now, every time that we agitated, we had more disinfection. So even with a weak antimicrobial agent such as CTTA, if we agitate, the agitation enhances penetration, enhances removal from the surface. So it's important for tissue dissolution, but it's also important for antimicrobial efficacy. Contact time. This is a clinical image. I like always to have a pulse chamber full of liquid. We often tend to do this problem where we are first preparing and then irrigating. Please keep your chemicals inside your tooth as long as you can. This will increase your action, your contact time, your disinfectant, your tissue dissolution will work a lot longer. I always tell my students, I would like to see the pulse chamber full of liquids like a swimming pool, but totally dry on the outside. So tooth wet inside and dry outside. Volume. We tend not to use a lot of irrigant. We sometimes use just 1 syringe, 2 syringe. There is good evidence that the more we use, the better antimicrobial efficacy. So this is a form of agitation because we use a large volume. The more liquid we use, the larger amount of debris will be removed. This is an important action. Now, we have a systematic review with analysis where we saw what happens from the patient-centered outcomes if you agitate. And we were quite surprised that we have quite a consistent answer where most papers told us that if you agitate, you will have less post-operative pain. So there are different levels. There is the microscopic level, and then there is the larger, the pain, the patient-centered outcome. So we always need to look at the different levels when we are treating patients. So with this, I would like to conclude saying that, well, from the laboratory studies, there are no doubts that agitating your root canal irrigant makes a big difference. Everything is a lot better. There will be a lot of contrast between sonic and ultrasonic, but agitate, please. And we have evidence that tells us that patients will have less pain if we do a good agitation. Of course, everything needs to be done carefully. We don't want irrigant going through the apex. We need to protect our patients. Okay, so agitate, but with care. And thank you very much for listening to me. And I would like to.
All right. Thank you so much for the brilliant lecture, guys. I think we covered a vast spectrum of topics. Giamperio, I have a question to you. we spoke a lot about biofilm biology, and Ronald spoke about irrigants, we spoke about activation. What is your perspective about using intracanal medicaments or inter-appointment dressings?
Sorry, my child needed to come. Okay, so sorry guys, can you start again? Sorry. Children.
So are they interested in your lectures?
Yes, they are interested.
Oh, very good.
They are interested in our work. Okay, sorry.
So what is your perspective of inter-appointment dressings or intracanal medicaments?
Well, I think it's a very important step in root canal treatment. We always need to see that this root canal treatment has got several steps, and every single step needs to be done correctly. In my opinion, medication is very important when we have an infected root canal space. Sometimes if you have a vital pulp, you might be able to do the correct treatment. But in the presence of infection and symptoms, it is very important. For me, it's very important to see that my patient is feeling better. So the fact that I do several visits allows me to see how the patient is feeling, how the tooth is evolving. So I believe the medication has got an important role, especially in symptomatic patients and in patients with infection.
Thank you, because that's a topic of a lot of controversy in literature. Some studies showing there's an effect and some studies showing no effect. So I think that's a case where it's better to be safe than sorry. So rather medicate, and then especially with an infected tooth. One of the questions which, as specialist odontologists, we always get asked after every lecture is, what kind of instrument do you want to use? Should I use rotary? Should I use reciprocating? I don't think there is any impact at all of these instruments on the disinfection perspective.
Yeah, I think we need to go back to this basic concept of cleaning and shaping that was introduced by Schilder. Because sometimes we think that our cleaning or disinfection finish when we just pass the last rotary file or when we get the reciprocation file to the working length. So what we are going to have is a canal that is fully shaped. So it has a conical form. It respects the anatomy, but it doesn't mean that it's fully clean, because the cleaning involves the removal of all the debris, the bacteria, and all the bacterial byproducts or irritants that are inside the root canal space. So I think there are like several points that we need to observe. For example, the more wide the canal, the more difficult it's going to be to clean it mechanically. The more transversal anatomy, the worse is the scenario. So technically, once we complete the shaping it means that when you just complete all your instrumentation with hand files, or rotary files, or reciprocation files, we need to activate or irrigate the root canal for a certain period of time to ensure that we are removing or flushing out all the debris and giving enough time, as Giamperio explained, for sodium hypochlorite to dissolve this tissue. Of course, young patients is going to take more time. They have more wide pole canal spaces. It's going to take more time for sodium hypochlorite compared to very skinny canals or very calcified canals, where the instrument is just going to remove all the peripheral denting around the root canal space. But I think this is a concept that we need to be aware of. It's just to decide to do the extra job or the additional step to continue irrigating and flushing out the debris from the root canal space after the mechanical cleaning. In some cases, we may need to, as Giamperio mentioned, we may need to use an antimicrobial, especially if the patient has symptoms, acute symptoms, sensitivity to percussion, or swelling. swelling, or some predictors of pain. Like, for example, there are some predictors of pain that is, for example, severe pain in a woman over 40 years old, retreatment. So these are like clinical decisions that cannot be investigated in vitro studies. But I think we just need to use some common sense.
Correct. So could we summarize to say that if you're treating only radiographs, instruments are enough. But if you're treating patients, disinfectants are more important.
It's correct. Yeah.
All right.
Sana, can we ask you something back? What do you think about using chlorhexidine, either as a main irrigant or as a final irrigant?
I like that question.
Yeah. I mean, that's again a common thought process, because I oftentimes see these discussion groups where people say, oh, you should use chlorhexidine because it's effective against E. faecalis. I mean, that's okay if we were 15 years behind. But now we understand that root canal biofilms are a lot of microorganisms. And what we also understand now is the biofilm structure rather than just planktonic isolates. So chlorhexidine probably is only effective on planktonic cells. It probably kills bacteria as planktonic cells. But against biofilms, it has absolutely no effect whatsoever. We saw that even in Ronald's slides. And that's something which we have done something in our lab as well. Chlorhexidine cannot do anything to biofilms. So as an irrigant, I don't think chlorhexidine has any role to play whatsoever. As an inter-appointment dressing, possibly yes, because with time, it does have some effect on the biofilm bacterial killing. But as an irrigant, chlorhexidine probably has zero effect at all. And we recently also summarized this evidence on the effect of chlorhexidine on endotoxins. And we found that it had no effect on endotoxins at all. So I don't see any need to use chlorhexidine in routine endodontic practice.
Thank you.
All right. Okay. So we probably then open up the floor for the audience to have some more questions after this. Yeah?
Okay, thank you.
Okay.
Thank you.
Thank you, guys.
So, hello, good morning, everyone who is joining in us from India, and a very, very warm welcome to everyone from all around the globe. It was a Herculean task to, get three of the best clinicians and researchers from three different corners of the globe and make them converge on World Dental Association and have this wonderful panel discussion that we are having right now. So I would like to welcome Dr. Professor Ronald from Minneapolis in USA, Professor Giamperio from Adelaide in Australia, and Dr. Prasanna Neelkantan from Hong Kong. It is really a pleasure to have all of you joining us. It is an afternoon. It's the previous of India. So it's been an amazing to get every one of us together. So I think so we can start. I guess Abhishek has a few questions collected from the comments which have been coming in. Abhishek, over to you.
I think he's mute.
Yeah,
We can't hear.
Yeah, I guess he is muted. No issues. I'll start. So I have a question about triple antibiotic paste. Either of you take it. I'm not directing the questions to anyone specific. It is open to all three of you. Anyone who wants to jump in and take the questions. So I have this question about triple antibiotic paste. How effective is it? And safe enough to keep it for a long duration? One of the things that's been mentioned about calcium hydroxide is you can't keep it for long duration. So is triple antibiotic paste also having some similar, negative effects on the tooth's structure, or is it safe enough other than the obvious discoloration effect that it might cause? So who would want to?
I think I can answer that question. I don't know. You can hear me.
Yes. Yes, we can hear you loud and clear.
Okay, so there is no doubt that the triple antibiotic paste is very effective. We published a paper like maybe 5 or 7 years ago, and it just can kill biofilm. The problem is that you have all these side effects, that is discoloration, and according to Mao Bing, that is from Temple, he has a follow-up study in like 80 cases. I think it was published like a couple of years ago with a group in China, and there's no difference with calcium hydroxide. The reason why the original protocol used triple antibiotic paste is because you cannot remove too much dentin in an immature root. So you have a tooth with an open apex, the mechanical debridement is limited. So it's just basically chemical debridement with sodium hypochlorite. They try to improve that in the past. However, I think the European Society of Endodontology is not recommending anymore because basically the outcome is the same. The other limitation is that we use some antibiotics that are prescribed for systemic diseases like doxycycline or metronidazole. And there's some, I mean, we don't know, but there's some risk of antibiotic resistance, maybe not in young patients, but over the years. Just remember, this patient is just going to take antibiotic for 20, 30 years over their life. And at some point, they can just make resistant to these antibiotics. So if you get the same outcome with, your common materials, you just go with the basics. Yep.
Can you hear me?
So,
yep.
Not you.
Yes, please.
Okay.
Yes.
Now
yes.
it will be interesting
Please.
to know what do you mean with keeping too long calcium hydroxide? Is it 7 days, 8 days, 9 days?
I think
When is it?
I think there's a couple of clinical studies that I like a lot. One is Margaret. I mean, everybody knows the Andreasen study where he put calcium hydroxide in extracted teeth for 30 days, 60 days, 90 days, 108 days, and even until 1 year. So after a month, these teeth start to fracture very easily. But I think a very well controlled, like not controlled, but like a series of cases or of consecutive cases is the paper from Margaret Ree and Rick Schwartz on the treatment of immature tooth. I think they have follow-ups. I think the short one is like probably 3 or 4 years until 10 years. In 80 cases, they didn't find any like vertical root fracture, but they reinforced the tooth with a fiber post. And I think there are like 2 types of bioceramics for apical plugs. Anyway, it is not recommended to use it for a very long period of time, especially if you're using 5% of full strength of sodium hypochlorite. But yeah, this is the only information that I know. I know you have more, Giamperio, maybe?
Well, the paper that really suggests that teeth were weaker, apart from the Andreasen, though, if you see there was no control, there was no obturated tooth. So you don't leave the tooth empty. You either obturate or dress it. So there was not really an appropriate control. So that's already something. Well, there is no control for this study. Now, there are several studies in vitro, as we said before, that say that dentin chunks will become weaker over time after 30 days. But in patients, there's not the same evidence. I think there's a historical paper from Zweck where teeth were very mature. Only in very mature teeth, traumatized teeth, calcium hydroxide make them more prone to fracture, but was not for every tooth. So we keep saying this. I also say it when it's convenient for me, I have to admit. But calcium hydroxide still needs to be proven that weakens the tooth from the clinical point of view.
Yep.
Rather than from the lab point of view.
Yeah, and this Andreasen group, I think they were not even human teeth.
Yeah, they were. We go through this every time because we have a lot of Scandinavian influence here. They were sheep teeth. I remember.
Yeah.
Now there was this difference. After 30 days, there were significant differences, but let's say between 30 and 60 days, there were none, if I remember well. So then I always tell people, then if you don't 30 days, then you could do 60 days because there is no difference. So the threshold is 30 days if you are following this paper. But again, the comparator was saline, which is not a treatment. You don't send patients home with saline. You either put a root filling material or a dressing. Okay.
What do you think, Prasanna?
I agree. I think most of these studies that report that calcium hydroxide weakens teeth is based on the fact that you don't fill them or you don't reinforce them, which is hardly the reflective clinical scenario. And then if you take a lot of these so-called dentine block studies, you have these studies where dentine blocks are completely immersed in these irrigants or in the dressings, which never happens clinically. It's one surface that's always touched. And this doesn't make, I don't think, from the clinical perspective, calcium hydroxide evaluating does not weaken teeth. And again, the question that Giamperio raised is very good. I mean, what's the threshold? How long is long? Are we
exactly? Is it 7 days? Is 8
Yeah, how
days?
long-
When is too long?
Yeah, the problem is, I think in the past with the apexification, you needed to wait until you form an apical barrier. So people used to place calcium hydroxide, send the patient back. Another 3 months, they check with a file. You didn't have any apical barrier, just put more calcium hydroxide. It was like a old school way before the MTA. And maybe some teeth they just fracture because the patient never had a permanent restoration.
Exactly. So
Yeah.
the calcium is not a cause-effect relationship there.
And these were probably mature and traumatized teeth, which have lost, have pulpal necrosis, and they were very large apex. So they were already weakened, plus they were still young, let's say were not really mature and strong, plus they suffer from a trauma. So you can't say that coronally they were already weaker. So there were several factors.
Yeah. We have an interesting question here from the audience, which I want to raise to Giamperio.
Thank you.
How can we eliminate biofilm in the periapical area during non-surgical treatment? I guess they also mean extraradicular biofilm. How can we eliminate, if there is, there's no way to know if there's an extraradicular biofilm, but how do we eliminate those biofilms during non-surgical treatment? Because our irritants clearly cannot be allowed to pass the periapical region.
Yeah, to be fair, we cannot really achieve that. I agree with the person that is asking the question. We should actually maintain all our protocols inside the root canal space for safety and what is required. We tend to change the environment. It's not a complete elimination of the biofilm, but it's a change of the environment. Just changing the intracanal infection often or very often leads to healing. And there is Ram Nair, who always says we do a lot of things that are imperfect, but root canal treatment has a fantastic success rate. So we need to understand that we don't need to really kill every single microorganism. If we change the environment in the area, we have a very high chance of success.
Agree. So it's probably impossible to eradicate microorganisms or to completely eliminate biofilms, as long as you can achieve a certain level of reduction where the body can heal. So Anand, Abhishek, are you happy that I take some of the questions and direct them to?
Yeah, please do that.
Yeah. All right. So there's one more nice question, which I know the answer to, but I would like to hear from Ronald. What's the best activation method in terms of biofilm removal? Is it sonic or ultrasonic?
Okay, so every tooth is different, and we have kind of a principle is that the more tapered, the better. After the probably size 30, 35, or 40, you will get a better flowability of the irrigant solution. That's one. You need to have some space for the backflow. And the activation is just catalyze the reaction. So basically, if the sodium hypochlorite would have enough time, it will dissolve biofilm and necrotic pulp. The problem is, inside the tooth, there is many inactivators. You have dentin debris, dentin chips, pulp, necrotic pulp, bacteria, blood, sometimes exudate, pus. So everything, just remember, sodium hypochlorite is an oxidant agent. It's going to react with any organic compound. So the reaction, the problem that has is just reduce the concentration. So it will just lose the concentration very quickly. So whatever we can do is just, improve the volume or improve the concentration or start to activate. So the one that is, I think the standard is just PUI, passive ultrasonic irrigation. If you can do it, if not, probably you need to go to sonic if you have a very curved canal. But basically, this is the protocol. Usually, it's like 90 seconds per canal space, and I think you need to have some common sense too. Oh, it's a kid around, yeah. You need to have like some common sense. If you use like 90 seconds of PUI, and then if you see that still you have like some reaction or just some bubbles coming out because there is a young patient, probably the patient is 10 years old, there is a lot of necrotic pulp, you may need more time compared to a very calcified canal in a mandibular incisor. It is just about how symptomatic is your patient too, but there is to be like some common sense. The provider needs to find how large is the root canal space that is treating and how much time is spent doing the instrumentation. If you feel basically that the liquid wasn't enough time to produce all this dissolution effect, you should place a medication and give a patient another appointment to just complete the cleaning. But I mean, if you have a patient, your patient is 60 years old, 70 years old, it's a calcified canine, you can go easily to a 5004, irrigate for 5-7 minutes. It just, everything comes out really clean. Probably you're ready for obturation. So it just, every tooth is different. But basically, PUI is my favorite tool to produce cavitation. Yep.
All right. So can we agree that all three of us consider ultrasonic to be a better strategy than sonic?
It depends.
I agree that. Can I just say that doing every step right is the best strategy. That is from the rubber dam, from caries removal to diagnosis to after treatment restoration. Right. This is the strategy. Then whatever you use it's just one step to go to heaven. If you miss one, you might not end up going there.
Yeah, you're building up a wall. So every brick is, you need to be.
Every brick is important. Yes, it starts from.
Important.
Yeah. But one thing which probably Giamperio knows my take on this. I try to usually differentiate agitation from activation, although there is no clear literature to talk about that. And I think from the activation perspective, ultrasonic definitely activates irrigants chemically, whereas sonic is not an effective medium there. But regardless of that, I think the take-home message should be that activation is important considering how complex an anatomy we have. There are a lot of variables that we can change, but one thing which we cannot change is the anatomy. And considering the complex anatomy, activation probably is important. Yeah. There's one question which I will take, which is on endodontic sealers and dentine condition with different irrigating solutions. So just I'll just briefly summarize the outcomes of the multiple studies that we have done. If your root canal sealer is going to be AH+, your last irrigant should not be sodium hypochlorite. And if your root canal sealer is going to be any of the tricalcium silicates, MTA, any of the so-called bioceramics, then your last irrigant cannot be hypochlorite, EDTA, or clohexidine. All the three of them prevent tricalcium silicates from biomineralizing. So what our group recommends is to use saline or a water rinse prior to any obturation protocol to ensure you remove all traces of irrigant. That would be a rather foolproof method. So key message here is that if it's AH+, no hypochlorite final rinse. And if it's any of the bioceramics, then your last rinse is preferably water or saline. None of the other active irrigants. Okay. What should be the minimum shape of what? I assume you mean minimum size. What should be the minimum size of the root canal to hold a sufficient amount of irrigant to perform its action? Ronald, do you want to take this?
Depends. I mean, let's see. If you use a 30 gauge needle, okay, you can use a 3004, a 3006. But if you're doing root canal in an immature tooth or in a central incisor in a young kid, that won't be enough because you will have like too many, necrotic tissue around. Probably should go more. But that's the minimal size. But the fact that you are reaching the working length with the needle, it doesn't mean that you are going to have a really quick cleaning of the root canal space. I mean, just remember, it's just mechanical debridement is also important as far as you don't destroy the tooth. But at least the 30 gauge makes sense in a curved canal. You can go 3004, 3504. Some people like 2508 too. I mean, it's 25 at the tip, but yeah, 2508 too. I mean, it just depends on the tooth. It's like, I know there is something important here. Every dentist needs to know his practice. You need to know your population. If you treat only retired people, your type of diagnosis, your problems are going to be completely different compared to you working in a health public system where your patients are really young or young adults. Of course, the way of thinking is, I mean, it is the same, but it is going to take more time in the young people to clean it. In the old people, the time that you're taking is doing the access and finding the canals because canals are so narrow, they're easy to clean. But I think it's at least 30 or 4, but I will just say it depends a lot on the anatomy and age and diagnosis too.
All right.
Can I just say one thing, Prasanna, that sometimes we want to have one protocol. We are like giving a uniform to people. We should actually try to have different protocols, which are for each patient, for each canal. We shouldn't send home dressed with a uniform. They should be dressed with the clothes that suit them the best. That's the difference. You don't need to have one protocol that you do everywhere. You need to have various protocols based on your diagnosis and the morphology. That's why we need to be talking about morphology, diagnosis, and then treatment, not just treatment first.
I think people sometimes they ask these questions because they think like restorative dentistry, where you have like etching, bonding. There is a protocol how to put everything in layers. I mean, it's a standard protocol for almost all teeth. In root canals, you're talking about diagnosis. Yeah. I mean, you have abscess, inflamed pulp, necrotic pulp, calcified, trauma, young patients, retreatment. There are like several variables, and then you just need to pick what is best for your patient. Yeah. The only recommendation is, if you are not 100% sure that you're managing the symptoms, you just make another appointment and just improve treatment until you get predictable treatments, and then once you know that what is working in your protocol, just as far as it's reasonable, you can just keep doing the same.
Yeah. So to summarize, we say you cannot actually have a recipe for root canal treatment.
We have principles. It's like principles.
We don't have step-by-step recipes. And as we said earlier, if you're only treating radiographs, you can be given step-by-step recipes. If you're treating patients, there's more to it that you need to apply from the evidence that you clean. There are a lot of questions here, which I think about 80% of questions here can be easily learned by a quick search on PubMed. So I'm only going to take a question which is more pragmatic, which is more opinionated rather than evidence. And this will be the last question, and we will close on a futuristic perspective. What's your take on photodynamic therapy?
I'm not an expert on that.
Let's say still there is the naughty answer. Is a great technology still to be demonstrated to have a clinical validity.
Correct.
Okay.
So at least from in vitro evidence, I think, at least from the work from Anil Kishan with photodynamic therapy, we know that that's probably the only regimen which is able to simultaneously remove biofilms and strengthen teeth by collagen cross-linking. With all other protocols, it can only achieve one of two purposes. But that said, of course, at present, we still don't have evidence from clinical studies. All we have is good in vitro evidence. But in the future, do you think we will all be shining lights into root canals?
Can I just also ask, there will be probably a very broad diversity on the chemicals that you place in the canal, the activation regimes, times, type of light, so
Interaction.
Correct. I mean, with regards to PDT, if at all I see a commercial variant coming up soon, of course, we have a commercial variant already from a company called Photosan, but the research base for Photosan is rather weak. There is not much of studies done with their chemicals. So if at all I see a robust protocol coming out of photodynamic therapy and a commercial availability, it has to be the Chitosan Rose Bengal combination from Kishan's group, which means that we have established protocols based on his papers, depending on how much time you activate, what kind of light you use, and so on and so forth. The other commercially available brands, as of now, most of them don't even have papers published on their photosensitizers. So it's very difficult for anyone to devise a protocol. We're going to have the same issue of 1,000 people doing 1,000 different things and then reporting that it makes no difference on outcomes.
The other question is, how many failures do you have to use that? I mean, I think that the failure is more related to the preoperative status, and then you can feel that if a case is going to fail, you can see it before initiating treatment. So there are like certain type of diagnosis and type of bone lesions that you know that it's not going to work. And I think that every new material that claims a superiority of treatment should be focused on treating these type of patients. It's not like, oh, we'll do just the easy cases, because the easy cases can be solved by regular by a standard technique. But I mean, the classic example that I like, that probably everybody knows about this, is a necrotic lateral incisor, maxillary lateral incisor, with a huge lesion, like 10 by 10, 10 by 12. You take a CBCT, there's no buccal plate, there's no lingual plate. There is an easy tooth, almost a straight canal, but that damn tooth is not going to heal. I mean, it will be you need to have a very young patient or do a decompression or some type of extra treatment to just get healing. So this is the type of cases where you see, we have, these PDT, photodynamic therapy, or nanomaterials. And then in these type of cases, you need to use it, and then is to prove if it works, because in a regular case, you see, I mean, you're comfortable. It's just, you don't get a lot of failures.
The question is, we have a success rate that is, I don't know, let's say 85%. Can we push it to 95 with something? That's the question we need to ask. Yeah, because if we keep having 85%, I'm not talking about anything specific. Can we push? Now, will only one of those steps to heaven be sufficient to take you to heaven quicker or more often?
Yeah, it's
like the full wall, start to finish. It has to be in totality.
No, I see this probably 15% of failures can be anticipated. So it is more related about, how long ago the tooth was necrotic. For example, the patient was 10 years old, got a trauma, and now it's 20 years later, the patient decides to get a root canal. Of course, it is not the same like a necrosis that happens, like the tooth was sensitive to cold 2 months ago, and now it's necrotic. So you don't have a long-standing infection. Like, these type of variables are the most important, and I think we should do a study focusing on this, type of group of patients, or to realize how far we can go to non-surgical treatment. Yep.
So you think? Sorry, can I ask,
Yeah,
Ronald, do you think it's biofilm maturity inside the canal and probably goes outside? That is
yeah.
really what makes the difference.
I think time is. I mean, there are like we have some research. It is not so organized in that area, but you can find studies. I mean, classic studies from Langeland or Seltzer, where you have a necrotic pulp and it's necrotic at the pulp chamber, but it still is vital in the apical third. So you have blood vessels, and then you have a lesion. So the bacteria is not there because probably the time wasn't enough. But if the bacteria colonize the apical ramification and the cementum and the external surface, it's just the immune system is the one that is going to dictate the healing. And now you have, like in the US, people with overweight, diabetics takes like 20 medications a day. So there are like some signs that are telling you, let's go get a conversation about your treatment. You have a huge sinus tract, no vocal plate. You have it's a make-a compromise. Probably non-surgical treatment is not going to be enough. It's just, and I don't know if in these failures that we get in the outcome studies, probably are this type of patients. Because we don't, our like inclusion criteria is very broad. We just take everybody.
I tend to be concerned in long-standing sinus tract because I see them away for let's say abscess to go out, but also bacteria to colonize the external surface of your tooth. So that's actually one of the things that make me feel negative when I start a treatment. There is a long-standing sinus tract. And on the other side, you are happy if the sinus tract heals because you see it rather quick. So let's say you could probably measure your outcome a lot quicker than other cases. Now, I understand sometimes sinus tracts can come back, but if it's still there, your treatment is not working. If it's healed, you know that you're going in the right direction a lot earlier.
Well, that's one advantage of two-step treatment. Yeah. I mean, sometimes you feel it. You have a gut feeling. I shouldn't obturate this, and then you're right. In second appointment, it's not healing. It's still there. Yeah. And then
because there's no way for us to check the efficiency of treatment intraradicular except looking at the signs and symptoms. There's no way we're going to say how each of our technical aspects is going to improvise on biofilm removal or its elimination in the clinical setting. So you really have to rely on what's happening to your patient before you see if you're going the right direction or not.
Yeah, I mean, it's like a kidney transplant. You just do the transplant, and then if it works, it works. That's why we have diagnosis to try to anticipate, because we know when the outcome is compromised. We know the variables. If you see that variable in that patient, I mean, just go with a realistic expectations. As far as you're doing everything good, your treatment is completely good. So that was because of the PDT. So the PDT, we read the last one, your last tool to try to treat something that is not working, probably.
Right, correct. All right.
That goes back to diagnosis. Sorry, Prasanna, goes back to diagnosis.
Yeah.
And morphology.
Possibly, yes. I think at the end of the day, it's not about the technique or what instrument you use, etc., etc. Those techniques probably help you a little bit, but it's the whole picture of that wall. It's a jigsaw puzzle, and any piece missing is missing. That's it. And just by asking, should I use instrument X or Y, or if I use a three-dimensional shaping instrument, will I do a better job? I think all those need to be put behind. We have to stop focusing on the technology and probably start coming back to the biological perspectives. All right, so it's pretty. It's probably midnight for Ronald already, isn't it?
Don't worry.
Is it past midnight for you, Ronald?
Yeah, I mean, I can. You have more questions? I'm a real.
But some of these questions, I think.
I don't know. Giamperio is.
Giamperio has.
It's a special day over there.
Today is Mother's Day in Australia,
Mother's
and I should
Day,
be having
yeah,
lunch.
Okay. I think most of the other questions I've seen them addressed in a lot of groups already, so I'm not going to go into some of them. Okay, I will just end with this. What's your opinion on intracanal heating of irrigants? Giamperio, do you have a take on intracanal heating?
You heat it before you put it or after you put it? That's
After you put it. I don't believe in heating before you put it. It's a waste of time. Let's talk about heating after you place the irrigant by the root canal.
It might work. It might work. I'm not sure how long it's going to last because your body has got such a big bulk that a little drop of liquid will cool down or will have a stable temperature with the liquid, because there are two different items with different temperature. So if something needs to be tested, it's a possibility, but I still need to see this happening. Okay, but as I'm telling you, we are mixing something, we are putting something very little inside something really big, which is your patient. So when you heat it, it will probably cool down quick. Also, we need to be careful with gingival necrosis, bone necrosis. I published a case where I caused a gingival necrosis by using for too long the heat source. So if you put too much heat, your papilla will disappear and the patient will not be very happy.
That's not good.
I know.
So sometimes these end up worsening clinical situations than actually being beneficial.
Exactly. Yeah, because often patients go to you for this crown margin doesn't look very good. Then you retreat the patient, and if you kill the papilla, then the patient will have a much bigger problem. I have published it. I'm sharing my mistakes. So you don't do the same.
Yeah, because I know some of the Italian groups. I've done some work with them. There's a person called Alfredo Iandolo from Italy who has been doing some of this internal heating work. Again, like many other things, what we need is some kind of optimized time and temperature so that people don't go haywire in overheating in a quest to try to eliminate biofilm from root canals and in the process eliminate the gingival papilla.
Yeah, that's fine. We need to see. Again, it's another thing. As long as we use with caution, it will the temperature will stabilize after a while. So you need to do something continuous. It's a defensive mechanism. It's a defensive mechanism of the body to keep a temperature constant.
Correct. Okay, I think we will end on that note. We'll probably just summarize by saying clinicians need to start looking more into the biological aspects of endo rather than focusing too much on the technical perspective alone. And every step is important. You're essentially building up a wall. So anything which you add up is only going to add up a little bit to what you're doing, but it starts all the way with diagnosis, rabdam application, coronal seal, and all that. And what happens in between could be made better to a certain extent, but the evidence, the clear-cut evidence on what exactly results in better outcomes is still unclear.
Okay.
Yep. All right. So we'll call it from our side.
Okay. Right? Thank you.
Okay.
Yeah. Thank you. Good night, Ronald.
I will send my address. You can send me my check, please. No, it's a pleasure.
Yeah. Thank you so much, Professor Ronald. Thank you so much.
Looking forward for the next one.
Yeah. Sure. Okay. Thank you so much, Professor Nasser. We should do. Thank you.
Yeah.
Bye-bye.
Thank you.
Okay. Bye-bye.